are one piece of the puzzle. We have curated resources that are curated by a bunch of experts that help us choose which article to read. We have podcasts in the offing. We have space to launch registries. We also have courses for entry-level physicians as a start that is being offered by both PHFI and AHPI together, the Public Health Foundation of India, the Association of Healthcare Professionals of India. And a young doctor or a doctor who's not familiar with COVID, who's handling these patients, can actually take these online courses and register with them. We also have plans to go forward with more webinars. We also bring together various associations. Our partners so far have been the Association of Healthcare Professionals of India, the Public Health Foundation of India, the Indian College of Physicians, Diabetes India, and the American College of Physicians Air India chapter. We're also looking forward to welcoming the Surgical and Critical Care Associations through this meeting, and of course the Obstetrics and Gynecological Association. So bringing people together, helping them collaborate and facilitate is what we do. We don't own the content, we don't own the copyright, we don't own the intellectual property. It belongs to people like Dr. Bala Venkat, who I'm introducing now as a person who's going to anchor this program. Dr. Bala Venkat is a renowned anesthesiologist from Coimbatore. He has tremendous expertise in his field, but more importantly, I want to talk about some of the two personal characteristics of him that made me really start admiring him. One is his commitment to this process. What he gets into, he does well, and he gives that enthusiasm to all of us to continue. The second is his almost self-effacing affability that makes you wonder what lies underneath that gives him that excellence. So, and he has assembled this big panel, and I'm going to ask Dr. Bala to take over from here. Dr. Bala, it's all yours.
Thank you so much, Dr. Krishna Seshadri, most popular and sought after endocrinologist known across this country, an internist. Thank you very much for lending a hand to the process to GCMC for making things happen in the pandemic. I sincerely thank Wipro International for establishing this platform of the Global Coalition for COVID-19 Medical Care and the phenomenal contribution they have done to this country, though they are not directly involved in a hospital or a medical care, being a pure technology leader, but knowing the Azim Premji Foundation, who contribute phenomenally, actually one of the biggest philanthropic organization of this country, who gave the minute the pandemic struck, Azim Premji Foundation announced, if I'm right, about 1,200 crores to the country to take care of the pandemic. And more importantly, they directly got involved in converting one of their facility into a COVID care center, a 500-bedded COVID care center in Pune, and then trying to go the extra mile to help the medical professionals to get the right kind of information so that patients survive, those who come to them, especially so when the pandemic unleashed and beds were not available, when the second and the third tier cities started opening small COVID care centers, there was dearth of information reaching them. And I think this platform has been extremely useful in conveying to them what needs to be done. With this introduction, thanks to Dr. Krishna and Dr. Vijay for spearheading the medical aspect and supporting Wipro International for making all this happen. And today's webinar is on surgery in the pandemic. I'm sure all of us will agree there have been several challenges. One of the challenges to treat COVID, contain the disease, but more importantly, one of the biggest challenges that we had is to operate patients during this pandemic. Either they're COVID positive or a suspect. And several patients have lost their life because in the smaller centers to which they went, surgeries were refused, including some pregnant patients who lost their life because they were not admitted in smaller centers, and they, by the time they reached a higher center, they had to lose their life. So we are moving into an era of post-COVID patients with several challenges offered to the perioperative period to the physicians because of certain features like the long COVID syndrome and the consequences of COVID in a patient. Hence, this webinar is going to be more of an interactive webinar with an excellent and esteemed faculty from across the globe to discuss certain pertinent points, especially to the Indian environment and the challenges that are posed in Indian environment. I take great pleasure in introducing, when I introduce, maybe I think you can wave to the delegates, Dr. Aruna Pujari, Head Department of Microbiology, and she also is the Center of Focus of Hospital Infection Control in one of the biggest corporate hospitals in Mumbai, the Breach Candy Hospital. Thank you, Dr. Aruna, for joining us today. We have Professor Dr. Shraddha Patka, the consultant surgeon, gastrointestinal and hepatobiliary surgeon of the popular cancer center in this country, the Tata Memorial Hospital, Mumbai. I think her inputs would be extremely important from the surgeon's perspective. We have Dr. Reena Jewani, Professor of Obstetrics and Gynecology, who has contributed and worked with a lot of COVID positive antenatal pregnant mothers from Dr. R.N. Cooper Hospital, Mumbai. Thank you so much, madam, for being with us. And it would be a pleasure to learn from you the several facets of treating these patients. We have with us Dr. Vishal Uppal. Dr. Vishal is an associate professor of anesthesia in the Dalhousie University, Halifax, Canada. He has done original publications and contributions and guidelines in anesthesia journals. And I think he, along with Dr. Rakesh, I think is just going to join us from the Iowa University, USA, contributed excellent articles which will help anesthesiologists across the globe to follow certain protocols and principles. I have great pleasure in introducing Dr. Jiggy Divatia, Head Department of Anesthesia and Critical Care at the Tata Memorial Hospital, Mumbai. There you see Dr. Divatia, and I have great pleasure in introducing Professor Dr. Anju Grewal, Professor of Anesthesia, Dayanand Medical College, Ludhiana, Punjab. Also have been in the thick of things of treating several COVID patients. I, on behalf of the GCCMC, take great pleasure in thanking each one of you for giving your time and for sharing your thoughts and experience and expertise today. We'll straight go on to the questionnaire session. Everything is going to be in the form of question and answers. And following which, we will also take questions from the participants. So may I request the participants to air their thoughts and concerns in the chat box. So maybe I'll first start with Dr. Aruna Pujari. One of the biggest concerns that is facing the medical profession today is whether to do an elective surgery or not. If I do an elective surgery, am I at a risk, and or the healthcare workers who are associated, will they be at increased risk? So many centers have not started doing elective surgeries for the fear of getting infected. So a patient who needs surgery, the first question I would wanted to ask, what is possibly the best screening test for any patient who is going to come for an elective surgery? And if we do this, what would be the sensitivity and specificity? And do we rely on these tests? Over to Dr. Aruna. You have to enable the audio, Dr. Aruna.
Sorry. Yeah, so before I take on the question directly of the testing, I think whether a facility or a healthcare institution decides to do elective surgeries or not would completely depend upon the type of infrastructure they have and how easily they can segregate their COVID patients from COVID and suspect patients from their non-COVID patients. So that kind of segregation needs to be correct and complete, and only then probably they should plan out elective surgeries, and that too may not be full-fledged. It could start off with one field and then take on with the other, depending upon what kind of resources they have and things like that. Now, if one decides to start with an elective surgical process, then the first thing naturally is going to be um, at the screening level itself would be a questionnaire, set of questionnaire that one would want to ask the patient. For example, whether the patient has been previously positive, whether the patient has been a high risk contact in the past 14 days, travel to high risk area. So this is a simple set of questions, symptoms if they are present, that the surgeon needs to ask the patient. Now, based on this, I think at this point in time where we are in the pandemic, we have people who are probably positive in the past meaning more than 3 weeks ago. We have patients who are currently positive, and we have patients who have never been positive or are not in the high risk group. So for a patient who is actually past positive, I think there's very good scope to do an antibody test and demonstrate that this person has got exposure and therefore has mounted an immune response to the SARS-CoV-2 virus, and there itself it would end. So in a patient who was past positive, at least 3 weeks past positive, demonstration of the antibodies would be a very good tool to take the patient up for surgery. Now, with respect to the sensitivity, more than 3 weeks past infection, the likelihood of developing antibodies is almost about 90%, 90 to 100%. So once you document antibodies in the patient and the patient does not have any symptoms, I think it would be reasonable to take this patient up for surgery. Now, if the patient is a high risk contact in the past 14 days or has symptoms, naturally one would want to think about whether really the elective surgical process is needed right now or it could be deferred. Now, for a patient who does not have any symptoms, wanting to get posted for a surgery, the best test to be done, as you asked, would naturally be a PCR, a real-time PCR. But having said that, what happens is we know that the real-time PCR, despite being the gold standard in the current situation, is not the best test. It has a sensitivity of probably just about 70%. And India is a setting that we have a lot of asymptomatic patients also. So I think, again, that also needs to be interpreted with caution. And if a person is going for a high risk procedure, particularly which involves the respiratory tract or the orodigestive tract, then in such situations, I think it would also be worthwhile to consider a radiology like a CT scan of the chest, because it's a sensitive tool. Again, I would not like to generalize the use of a CT scan, but it could be selectively used for certain high risk procedures. So there's no single test, but here I would certainly like to say a lot of people are using the antigen test, which is supposed to be a rapid test giving results in 30 minutes and so on and so forth, as the screening test for posting patients for elective surgery. Please avoid doing that, because the antigen test, even in a symptomatic patient, has a sensitivity of about 40 to 45%. So an asymptomatic patient, it is going to be further worse. So don't use an antigen test to post your patients for elective surgery. Use a PCR, and definitely the history will make a lot of difference. And how you are going to use your antibody-based test also will make a lot of difference in this scenario of having a lot of asymptomatic patients.
Madam, regarding the antibody test, is there a cutoff or?
Yes. So most commercial assays where we use either an ELISA kits will have their own cutoffs, but most commercial platforms which are based on chemiluminescence have a cutoff of more than 1. Anything more than 1 gets reported as reactive in such assays. So if you have a reactive assay, it would suggest that this patient been past infected and has mounted an immune response.
Thank you so much, Dr. Aruna, for that. Dr. Vishal, would you like to add anything to, or what is the practice in Canada in relationship to testing a patient who is posted for a surgery?
So this is a moving goalpost, as with most of the places. So the practice keeps changing as the pandemic changes as well. So we just got the guidelines yesterday because for the first time we've heard community spread in our communities here. So what we are doing right now is similar to what Dr. Aruna said already. PCR is what we're doing. And again, we start with the symptoms, and if the patient is symptomatic, then they go into that pathway of needing. And if they're coming from the hot spot where they could be exposed, then they need testing and they follow the kind of COVID path if they're positive. If they're not, then they follow a normal pathway where we try to separate these COVID positive or suspected patients from who are not suspected, to keep them separate so that there is no cross contamination. So that's what we are doing in nutshell. I can talk about it afterwards when the rest of the panel is done with their part of things, which will make it much more intuitive.
Yeah, thank you, Dr. Vishal. I think there's another question which Dr. Divatia posed now. Dr. Aruna, can you take that question about the antibody? If the antibody titer is good, does it mean the patient has got immunity and will possibly not get reinfected, or it's just a neutralizing antibody?
So I think the commercial assays that are available in the market are of two types. One, in fact, three types, I must say. One that detects whose target antigen is the nucleocapsid protein. The second one, which has a target antigen, which is the spike protein, and the third one, which has the target antigen as the RBD protein. Now, the RBD and the spike, because the receptor binding protein is actually a part of the spike protein. So the spike protein and the RBD tests that are there, that targets that are there, these produce neutralizing antibodies, whereas the nucleocapsid ones don't produce neutralizing antibodies. So if you do, whenever you do an antibody test, find out what is the target antigen. Now, if your target antigen is nucleocapsid, it only will suggest that this patient has been past exposed. Now, if you have a target antigen which is a nucleocapsid or an RBD protein, then it indicates that there is past infection plus that these are neutralizing antibodies. Now, while I say this, the correct way of actually demonstrating neutralizing antibodies is a completely different method, which uses a different ELISA-based test, and it is not commercially available as of now. So yet, if you use the RBD and the spike protein-based antibody test, it should indicate both infection and immunity because they are neutralizing in nature.
I think that's a very, very important take-home message that you have given, because people generally talk about antibodies without going into the specifics. So today you have given the clear pathway that when you ask for it, probably you can ask the laboratory in which you're going to test it about which specific antigen that this antibody. Excellent, Dr. Aruna. Thank you very much for that information. And the next question again is to Dr. Aruna. I just wanted to know, people speak so much about when they do an RT-PCR test, the CT value comes and people grade it mild, moderate, severe in terms of viral load. Does it have any clinical significance, or it is doesn't have any role?
So the CT value basically is just an intersection point where, you know, the amplification curve. This is completely a microbiology term actually to be used by us in the laboratory, and unfortunately it's gone out in the hands of everyone, including the patients. So basically for us, it is for a particular run of a real-time PCR, it is supposed to be the intersection of the amplification curve and the threshold fluorescence. So beyond which we will consider the result as positive. And if it is a quantification assay, that is a viral load assay, then we will, based upon that CT value, we will be able to estimate the number of copies or the international units. Now, the current strategy of doing real-time PCRs for COVID is a qualitative strategy. So we give you a result which says detected or not detected. We don't give you the viral copies or the copy, meaning the number of viral particles in international units per ml. That's a completely different assay, which would be called as a quantification assay. And there we would use the CT value better and it would have clinical significance. So in the current situation of using a qualitative test, the CT value really does not have any roles, and it cannot be extrapolated to a higher CT value having less number of viral copies and a lower CT value having more number of viral copies. I think we should be very clear about this. And therefore, if you really want to make a difference, it would be doing viral loads and understanding the clinical significance of CT values using viral loads. But in the current situation of a pandemic, it wouldn't be possible for us to go ahead and do quantification assays for everyone. It's not possible, it's not required also. So I think that when doing qualitative real-time PCRs as we are doing now, CT values do not have much significance, and that is also one of the reasons why ICMR brought in a notification saying that it should not be reported onto a patient report because it does not have much value. And it, in fact, I must say that CT values change with different kits. They change with different specimens of the same patient. They change when the same specimen is run on 2 different cycles. So, we must understand that in the current situation, it's of not much use. If you were to do quantitative PCR, that has a complete different methodology in the lab. There it would be useful.
Okay, I think that's very clearly explained. And at present, so the take-home message is, do not worry about the CT value.
Yes.
It's a microbiological term, and we have nothing to do with that, and not to give any more importance to that. Welcome to Dr. Rakesh, who has just joined us. Thank you, Dr. Rakesh, for joining us. And Dr. Rakesh is from the Iowa University, US, and along with Dr. Vishal, had published excellent guidelines for anesthesiologists to use during the COVID time. So continuing this, like patients are coming, so we discussed about RT-PCR and antibody as a kind of a screening test for elective surgeries during the pandemic to go ahead and do procedures without possibly too much of fanfare. Now, may I ask the question to Dr. Divatia? In elective surgery, RT-PCR is negative, but patient is symptomatic. So what is the strategy that you would follow if RT-PCR negative, patient symptomatic, posted for an elective surgery?
So if the patient, in the setting of this current pandemic, right, if the patient has symptoms and the RT-PCR is negative, then there are 2 or 3 things we can do. One is, and the surgery is of course elective, as you mentioned. One is you can go ahead and repeat the PCR after 2 days, the patient isolating, and because you see the patient has symptoms. So if you do the test very early when the symptoms are on, you may or may not get a RT-PCR positive, or you could repeat it and then see what happens. The other thing you could do is, depending on the kind of surgery he's planned for example, if he's having thoracic surgery or upper abdominal surgery, maybe a CT scan might help you in give you some additional information. And the third thing, if it is purely elective, I think you could just defer the surgery and just wait for another 2 weeks and then check the patient out again. So
so, sir, I think from what you said, there are a few options. I wanted to know, Dr. Anju, do you use HRCT as a preoperative evaluation in an RT-PCR negative patient coming for surgery with symptoms?
Only in a select group of patients do we use this tool. Most of the times we go, as by Dr. Devatia said, we defer the case, we monitor, and perhaps take him at 2 weeks later.
Okay. So are there any other difference of opinion, Dr. Rakesh?
Thanks for inviting me to the webinar. In our center, we were like in Iowa, especially, we are really hit hard by COVID. Our test positivity rate is almost 40% right now. So right from April, we are having these same guidelines, except that if somebody tests positive, we just cancel their case, and we mainly do RT-PCR. Only rapid antigen test is being done if the patient is presumptive positive coming for an emergency surgery. And again, that is followed up with RT-PCR. And RT-PCR values come within 5-6 hours here. So the only other difference is that if they are positive in the past, and if they are asymptomatic, like for more than 2 weeks, despite what symptoms they have, if they are fever-free, if they don't have cough, breathlessness, we take them for surgery, which is kind of dicey right now because we don't know the long-term impact of the disease, and we don't even evaluate these patients for the long-term impact of the disease. But our institutional policy or even the government policy say that, oh, if they are asymptomatic beyond 2 weeks, which is to say if they are fever-free only, then you can go ahead and anesthetize them. That is still a little bit dicey right now.
Thank you, Dr. Rakesh. Dr. Reena Mani wanted to add a point.
Yes. There are two important points. Antibody testing does not change your status for elective surgery, so we really don't do antibody testing. With the past positivity, even if the antibody is positive, it does not guarantee that they have not been exposed, and cases have been reported in Mumbai about a second round of infection, and most patients' antibody titers decline. I have myself seen a couple of cases where there was a clear-cut case of COVID and the antibodies have come low and few healthcare workers have got a second round of infection. So for elective surgery, RT-PCR is the gold standard, and rapid antigen test has been used for emergency surgeries, but unfortunately there's been a mismatch between the two. So in obs and gynae, we sometimes have to go by rapid antigen test, which is not the gold standard. So I think the important take-home message which surgeons should keep in mind is that a positive test in RT-PCR is a guarantee, but a negative test in a symptomatic patient should be taken cautiously. And if it's truly an elective surgery, postpone it, because 1/3 of RT-PCRs in the best of hands will be a false negative, although it is the gold standard test. So like what you asked about the testing, if the RT-PCR also has come negative, but the patient is symptomatic, you can do the HRCT as a further screening method. It is not used routinely in most of the public hospitals, but a lot of people in private practice are insisting on both the RT-PCR and HRCT for elective surgeries. So I think that is an important message for people.
Yes, Dr. Aruna?
So I think one thing that we need to be clear, if the patient is symptomatic, it's best not to go ahead with any kind of elective surgery. So
yes,
that needs to be very, very clear. If we shouldn't.
So I think this is, I spent quite a time in this because this forms the basis of care. And if we really know what we need to do and what will be the protocol and the pathway, it becomes clear. So in a nutshell, with all the inputs that we have got, I think the take-home message is the gold standard is RT-PCR. But if the RT-PCR is negative but patient is symptomatic, if the patient can wait, postpone the surgery for 2 weeks. Or if it's in some centers where they would want to do, then probably a HRCT they may do, but that is not advocated across as a general rule. So with this in mind, if the patient is COVID positive, he needs a semi-urgent surgery. Dr. Aruna, are there any biomarkers that will help us to quantify the intensity of the disease, and whether with this we can say or predict the possible outcome in a patient?
So I think the biomarkers remain the same. The first thing is going to be the clinical status of your patient. And if this is going to be an emergency surgery, naturally there's something critical, and that's the reason why this is the surgery is being posted despite the patient being positive. I think the common markers that we follow for any COVID patient is CRP, then D-dimer, occasionally ferritin and IL-6 if they are available in the healthcare institutions. And I think neutrophil to lymphocyte ratio is another very important prognostic marker that has been utilized to assess how the patient will, meaning for prognosis. So these could be the markers that one could monitor. If you're suspecting a superadded infection, then naturally it's going to be procalcitonin serves as a useful marker.
Actually, there is a question from Dr. Rakesh. Can you clarify? Did you see the chat box?
So I'm talking about respiratory symptoms. I'm not talking about meaning the emergency surgery for which the patient has come in. The symptomatic patient is a patient who probably has respiratory symptoms and is likely to be COVID or is COVID positive, and now has landed up with another reason why he has to undergo an emergency surgery. For example, if it is appendectomy or something else and something else.
So in which case,
fever, cough.
Yeah, in which case, Dr. Vishal, do we think that patients who are COVID positive, who need a surgery, do we electively do the biomarkers, get interpretation from them, and explain to the relatives that the biomarkers indicate inflammation and patient can possibly go into complications?
So that's a great question, Dr. Bala. First of all, I have to say that one thing I think all of us are saying, and the audience should get it, is if the patient is symptomatic and positive and the surgery is elective, there is no doubt that we should postpone it for 2 weeks, as you said. So the question comes now, what we're into territory is that patient is positive or symptomatic, and we are needing a surgery which is either emergent or semi-elective. So emergent is again pretty clear. We have to do the surgery. There is no other way we can postpone it. But if it's semi-urgent, then this gray area comes into picture, whether we should proceed or not to proceed. So we can do, in our setup, we don't do any biomarkers. We usually just go by symptoms and PCR positive. If the symptoms are there, if the patient is saturating 89% on air, we know that patient is not good, patient is not ready. So if a 48-hour or 24 hours can make a difference, can improve their clinical status, that's probably the way to do. The best would be if we can wait for 14 days, as you said. But if not, then how long can we wait, and how urgent is the surgery? It's a difficult decision which has to be decided as a team. But luckily, there are fewer patients in this category. Most of the patients are elective, where we can make that decision easily, or emergent, where we have to go with the surgery. So these patients have to be discussed by the surgical team, anesthesia team, and the patients, and then the decisions have to be made. We can do hundreds of biomarkers, but ultimately what we want is a good outcome for the patient. And that will predominantly be determined by the symptoms of the patient, the clinical condition of the patient. I hope panel members will agree with me.
Okay, thank you so much, Dr. Vishal, for making a lot of clarity in about how to approach a case and how important is symptom, then the biochemical values. So thank you for that. And again, one more question to Dr. Aruna. When we get an RT-PCR positive case, elective surgery, you say we are postponing the surgery for 2 weeks. And then after 2 weeks, when we again repeat an RT-PCR, Now, the concern is if it comes negative, all of us are happy and you go ahead with the surgery. But if again it becomes positive, what should we do? With the background that everyone says that after 2 weeks, even if the RT-PCR is positive, patient is not infective. Do we accept this statement, or what should the stand be taken if after 2 weeks if the RT-PCR is positive?
Okay, I think once again we should come back to the clinical status, whether the patient is fit enough for undergoing a surgery. That's one.
No, he is fit.
Very
But
good.
the concern is the healthcare workers.
Good. So the next aspect of it is that the PCR is positive even after 2 weeks, and that is something that is even meaning we all know that the PCR can remain positive for 4 weeks, sometimes even 6 weeks is what we have seen the PCRs remaining positive. And yet, whatever published literature about viral cultures and PCR correlation that has come in suggests that by day 10, most of these patients, the virus is non-viable, and therefore the patient becomes non-infectious by day 10. And that's probably one more reason why even CDC has said that for mild and asymptomatic patients, you can discontinue isolation precautions after day 10. So in such a situation, if your patient is fit from the point of view of healthcare worker safety, this patient can be taken up for a surgery even if the PCR is positive.
So that's an excellent input for every surgical colleague and anesthesia colleague or all the doctors who are listening to this. RT-PCR positive, elective surgery, wait for 2 weeks, repeat RT-PCR, or in some cases even you know that there is no infectivity after 10 days. So whether you do an repeat RT-PCR or not is your institutional protocol. But as Dr. Aruna said, they're no more infective after 14 days. And if the patient is clinically fit and asymptomatic, please go ahead with the surgery. Would that be the take-home message for everyone?
Yes, I want to add one more thing that, we don't, like, I just want to share my experience that we don't retest in our center at all. Once they are positive, we don't retest them for 3 months, 12 weeks, first thing. Second thing, I want to add only one more point to what Vishal said. Biomarkers have prognostic capability in a COVID-19 positive patient. D-dimers have been shown to correlate with the mortality rate in a recent study in an ICU patients who are intubated. If it was more than 1,000 value, then there was more mortality in patients with ARDS. But for an elective case, anesthesia, it has very little implications, more for prognostication.
Okay. So thank you so much, Dr. Rakesh. And now moving on. So now we have got some clarity on what to do with the investigations for patients who come for surgery. Dr. Anju, actually now the concern also is, can you briefly let us know the protocol that is to be followed in doing an emergency surgery? As an anesthesiologist, we don't have time to get the tests done. But in the interest of saving a life, I think we need to go ahead and do the surgery. So can you briefly let us know the protocols that you follow in your institution in an emergency surgery? Suspect COVID, you don't have time to do the tests.
In our hospital, we have designated a COVID theater, and we also have a dedicated pathway for a multidisciplinary dedicated pathway. So as soon as such a kind of a patient is notified, we do evaluate that patient at the source, wherever the patient is there, do all our paperwork, prepare ourselves, and we treat it as a COVID positive, and we go ahead with protocols as we would be doing for a COVID positive patient. And take the similar kind of precautions and go ahead with the case.
Madam, when you say consider COVID positive and go ahead, there are a lot of small hospitals in this country which had closed down for a long time and which wanted to open. And do you have a suggestion for them on what pathway they need to follow? Just 1, 2, 3, 4 clear steps to make sure that surgery is done and people don't get infected.
So one is that you evaluate your patient at the site where the patient is currently admitted preoperatively, do all your paperwork there. have your notify your theater and the staff and the surgeon, and so that we can prepare ourselves for the case coming in. While we're doing the case, we transfer the patient directly to the theater, and we do a case as per the clinical condition. Of course, we prefer regional anesthesia wherever feasible. It all depends upon the kind of surgery and the patient profile that we're looking at. And the only thing perhaps we do differently for them is that as they're COVID suspects, we have already sent in their samples. We place them into a recovery, which is designated for COVID suspect. We don't send them to COVID positive areas. And we put them in that PACU till the report comes in. So, and however, intraoperatively, we do take all our airborne as well as droplet and precautions. We do don our PP, and we limit our personnel, and we follow the protocols in the theater. Outside, we do nurse them and take precautions till the report comes in. And then, of course, we send them to the specified area. If they're positive, they go to a COVID isolation area. If they're non-positive, they test negative, then we send them to an HDU where they are looked after.
So thank you so much, Dr. Anju. Dr. Vishal, do you think if it's a COVID positive case, is there a way that you will advocate the kind of anesthesia or the better outcomes, or in terms of aerosol generation? Do you prefer certain kind of anesthesia, and what would be your advocacy?
Yeah, again, I think we have to start with the beginning. First of all, can we wait for 2 weeks or not? If the surgery doesn't need to be done, okay, patient is COVID positive and the surgery doesn't need to be done urgently within 2 weeks, we should wait. But assuming the question is that the surgery needs done, it's more urgent and can't wait for 2 weeks. So the options we have are very limited. Like if you look at the factors, modifiable ones are hardly anything, except for when you look at the studies, large studies by COVID Surge Group, there is a signal towards a regional anesthesia being slightly favoring the outcomes for patients. So we are talking about here, all the way we have been talking about when patient does better, what is best for patient. And now we are in a situation for the first time, we have to think about both. We have to think about patient as well as healthcare workers, So in this setting, looks like the regional anesthesia is favorable. It's even just common sense. Like if someone has a chest infection, doing a general anesthesia is probably not going to be best for them. So principles are the same with COVID. If you decided to carry on with the surgery and they have some kind of chest infection, avoiding a GA for the patient with evidence and common sense would be sensible. Then when we're talking about the second part, which is healthcare workers, and we know, and in fact, it has been shown again and again that the aerosol generation caused by intubation is a part of general anesthesia. Aerosol generation, the risk of healthcare workers getting infection who are intubating is 6.6 times the odds compared to those who are not intubating. Bag mask ventilation was again associated with higher risk of transmission to the healthcare workers. So avoiding general anesthesia is probably going to avoid these things. Having said that, we cannot assume that all the patients will be done in regional anesthesia. Sometimes we have to urgently convert to general anesthesia. So we have to be prepared for conversion to general anesthesia. But avoiding general anesthesia and aerosol generation is always going to be a sensible strategy for all people around in the OR. I hope that has answered your question.
Yeah, yes, Dr. Vishal. I think again, the take-home message is if you can wait for 2 weeks, you can wait. If you need to definitely do the surgery, whenever possible, regional anesthesia is better than general anesthesia. But even when you give regional anesthesia, maybe mentally be prepared to convert it to a general anesthesia if needed, with adequate precautions to make sure that the healthcare workers don't get infected with aerosols. Um, Dr. Divatia sir, just wanted to ask you, because you have been extremely busy during this pandemic being a cancer center, and also knowing the fact that anesthesiologists are involved in a pre-anesthetic evaluation in the patients who are coming in, who could be a suspect or positive, the OP patients. So what protocols that you follow to make sure that your anesthetists don't get infected while doing a pre-anesthetic assessment?
So I think that's a very important aspect, focusing away from the operation theater to actually the pre-anesthetic checkup. So there are 3 or 4 things that we can do. One is we try and get as much information online or off without patient contact as possible, and we can do it electronically. We go through electronic records, so you cut down the amount of time you spend with the patient. Uh, what has also been shown very recently is that we all know that intubation and bag mask ventilation are aerosol generating, but a patient coughing is probably more aerosol generating than any of the many of the procedures that we do. So I think it is very important that even in the outpatient area, we must be adequately protected with N95 masks and so on. And the patients must also wear masks. Uh, so when you talk, so one is you reduce the amount of time you spend with the patient, have it do your PAC in a well ventilated room rather than in a closed small room with window air conditioning or with central air conditioning. Uh, Make sure that the anesthetist who's conducting the checkup has the N95 mask and gown and gloves and so on. And when you are examining the patient, if you have to examine the patient, maybe it's nice to auscultate from the back rather than from the front. Just try and avoid direct contact with the patient. So we will discuss what sort of tests we're going to do. So I won't get into that. But as far as protecting ourselves, I think just make sure you're wearing at least an N95 mask, a face shield, or goggles, and a gown when you're examining patients.
Thank you, sir. Dr. Rakesh, do you want to add anything to that, or what do you do in Iowa? Because a pre-anesthetic clinic, when the patient comes in, definitely they don't have a test in hand. So how do you manage it?
Yeah, I think we have gone almost as much telephone visits as much as possible, and virtual visits for these patients. So we contact them via Skype or telephone, even perform as much examination as possible so that they don't travel all the way to the hospital and catch a COVID in the interim or catch a infection in the hospital. And also it decreases the traffic in hospital too. So we have gone almost 80% of our healthcare visits, telehealth visits, basically. And those who come basically are always in a mask, and only during airway examination, we just lower their mask and take a look at their airway assessment. But for the rest of the period, they are in face mask and face shield in hospital when we are examining the patient.
So when you're asking this question, just again would wanted to ask, when you're in a hospital environment, when there is no aerosol generating procedure, for example, you're in the outpatient department, is it important to wear an N95 mask, or is a 3-ply surgical mask is sufficient enough to protect yourself when the patient also is wearing a 3-ply surgical mask?
Yeah, that's a very important question, and thanks for asking that. There is little evidence to show that N95 is better than 3-ply masks in a ward setting, in the out of operating room hospital setting to the healthcare worker. So, and also N95 requires N95 fit testing if you are to use it properly. And it is also cumbersome, it increases the work of breathing. Right now, it's known that COVID is mainly spreads through contact and droplets, and aerosol generating procedures are the ones which lead to aerosol way of transmission. So right now, by WHO guidelines and CDC guidelines, we have to take it as that it's transmitting through droplet and contact routes. And so 3-ply mask is more than sufficient, and that's what we use.
So I think this is a very, very important take-home message, because whether the patient is panting or not, with N95 mask, every healthcare worker is panting. Everyone is becoming hypoxic. So I think this is a very important information, that when it's not an aerosol generating procedure, on either side, if it is a 3-ply surgical mask, this would be sufficient enough to protect each one of us very well. Thank you so much for that input, Dr. Rakesh. Having spent time on what investigations we do, what pre-anesthetic checkup we do, what kind of mask we wear, what kind of PPE is okay, the teleconsult, we move on to the operating room. And one of the before that, we will go to the labor room. Actually, Dr. Inamani is here because one of the biggest concerns in this country has been pregnant patients who are COVID positive. And you have such a rich experience. Can you share with us the strategies that you followed in looking after pregnant COVID patients coming for a C-section and also coming for a normal vaginal delivery?
Thank you, Dr. Bala, for this very important question. We are now on the 6th version of ICMR guidelines for testing, in which there have been changes in the guidelines for how to test pregnant women coming for delivery or cesarean. But to cut the long story short, the way we stand today is that any pregnant women whom you are anticipating delivery within 5 days, or you think she's admitted to hospital for any care, we are supposed to test her at entry. So the RT-PCR needs to be done. The second thing is that if you need to take up, the previous question was discussing taking up a patient for emergency surgery. Labor and cesarean are both in emergencies. Often we have patients who are coming from cluster or containment or hotspot areas who need to be tested, who are not symptomatic. But as per the ICMR guidelines, all pregnant women should be tested whether they are symptomatic or not. We do the rapid antigen test and the RT-PCR both. Now, rapid antigen test has also been recommended as a screening because the turnaround time is very short. You get the report very quickly. If you have a rapid antigen test positive, you treat her as COVID positive, but you cannot deny her delivery or access to birthing facilities. You just have to take full precautions. But unfortunately, there is a mismatch sometimes between the rapid antigen test and RT-PCR. So the policy we are following, we are using universal precautions in all patients. Somebody who's found to be positive on the screening is delivered in a separate labor room or a separate labor OT, which is then sanitized after the procedure. To date, we have actually sent home more than 400 mothers and babies who were detected to be COVID positive. Most of them, I would say 95% of them, were asymptomatic and screened in the pandemic. I'm talking about the last 4 months. In the symptomatic patients, we had a positive rate of the RT-PCR of almost 50%. Half of the symptomatic pregnant women who came for labor and delivery with fever or cough or other symptoms were found to be positive. But even in the asymptomatic, up to 5 to 10% based on the phase of time we went through cycles. Now we are getting a lower number positive. Up to 10% of asymptomatic pregnant women were also positive. So what is the message I'm giving here? In the labor room, we have to be careful all the time. So protection with the face shield, the N95 mask, is recommended by us for our team for all splash generating procedures, because labor and delivery amniotic fluid also and peritoneal fluid, which may splash cesarean section, both have been thought as possible areas of infection other than the respiratory droplets we talk about. So hence, precautions in these situations is recommended for the healthcare workers, from the doctor up to the cleaner, the person who is removing all those the fluids and mopping up after. So looking after the whole team is very important in the labor room and in the cesarean OT.
Thank you, madam. Actually, there are two questions which I would wanted to take from what you said. I'm not sure if Vishal can take this. Is this true that the peritoneal fluid is also infective? Is it true? Has it been proved?
I will have to do a pass on that question, but what I can say just now is the maximum respiratory load, from what we understand, the maximum viral load is in respiratory secretions. And Dr. Aruna can tell more about this. But most of the, like, it has been detected in CSF, it's been detected in other places, but the infectivity of what is questionable. But at the same time, I agree with Dr. Reena, it's better to be safe than sorry. But I'll let Dr. Aruna throw more light on this one.
I think there was one paper from Italy which talked about peritoneal swabs coming positive, and that actually raised the alarm. But I agree. I think in this pandemic, we should be better safe and ensure that our healthcare workers remain protected. And therefore, whatever maximum protection that is required in that situation should be given to all healthcare workers who are working in that area, irrespective of whatever sample. And of course, respiratory samples are the most infective.
I want to add something to this. Like usually, like there's a report from New York saying that almost 90% of pregnant women who are asymptomatic turned out to be COVID positive. So the percentage turning out positive, 90% of them were asymptomatic, first thing. Second thing is, second stage of labor is considered aerosol generation because they are panting and puffing and they're exhaling and inhaling a lot. So the deep respiratory excursions can generate aerosol in that sense, irrespective whether amniotic fluid or peritoneal contents have COVID in it. But the respiratory excursions can be presumed to be, and that's why even the ASRA position statement on OB says that second stage of labor can be considered as aerosol generation.
Yeah. So in connection to this, can I ask Dr. Shraddha Patkar, Madam, there are a lot of noise that has been made about doing a laparoscopic surgery in a COVID positive case or in a suspect. What is the current stand that the surgeons have taken in respect to this aspect?
So initially, when the pandemic started, there was a huge hue and cry about the aerosol which is generating during the air insufflation for creating a pneumoperitoneum. And even the SAGES, which is the authority in issuing guidelines, say that it's probably best to defer laparoscopic surgery. They modified their stand later on. Actually, if you see, if the pneumoperitoneum or the air which is insufflated during a laparoscopic surgery, if it's in a controlled environment and you can let out the air also through a specific designated port with an excellent sealing system which are available right now, the risk to the healthcare workers or the staff and the OT personnel is actually less because you're venting it out in an absolutely controlled environment and not letting it out to the OR in general. So currently the stand is that laparoscopic surgery is safe, and even the Tata Memorial Hospital has published experience of doing reported to either the
Dr. Shraddha?
Yes.
Yes, ma'am. Now you can. Yeah. In between, we couldn't.
Yeah.
The audio, we were not able to hear your audio.
Okay. So, as I said, that if the pneumoperitoneum or the air which is insufflating during a laparoscopic surgery can be vented in a controlled environment with a proper sealing system, which are available. There are company-made systems which are available. It's called an air seal, and they are connected to the laparoscopic port. The risk to the OR personnel as well as the patient is minimal. And so laparoscopic has its role currently, and there is no great evidence to stop doing laparoscopic surgery. In fact, with the added advantage that the hospitalization is minimal, the blood loss is less, the turnaround time is lesser in the hospital. You can actually benefit the patient more by sending them home rather than an open surgery in which the patient probably has to stay in the hospital for a longer period of time.
Dr. Shraddha, in continuation with, as a surgeon, what kind of protocols that you followed during this pandemic, even if whether you're operating a COVID positive or a suspect, what kind of PPE were you wearing, and what was the discomfort that it produced? And do you believe that even in suspects, you need to wear a PPE to operate?
So again, coming back to what was the risk of aerosol generation during the procedure was the thing which was in our mind first. If there was a procedure like a tracheostomy, for example, or a bronchoscopy which had to be done, then the extreme precautions were taken with the full PPE, and the patient was taken in a treated as a suspect COVID and taken in a COVID positive OT. Actually, initially when we started our pre-op testing, it was mainly based on symptoms. But as the number of cases increased, we probably moved to a routine pre-op testing for all our patients. And with increasing the asymptomatic positive rate, we actually decided that if a patient is at a higher risk of aerosol generating procedure, it may be prudent to take them in a separate OT and then probably wait till the results are available and then move them to the general ward, because that reduces the risk to the healthcare professionals as well as other patients who may be in the vicinity.
Okay. What is the protocol that you follow in doing being a hepatobiliary and gastrointestinal surgical team in endoscopies, which are supposed to be one of the real aerosol generating procedures? So do all in the endoscopy room, everyone is in a PPE when you get an endoscopy done in all your cases during this pandemic?
So initially what happened is when we had some short procedures like probably a nasojejunal tube insertion in which the contact time was not more than 15 minutes. It was not a full PPE which was made available, but just a proper N95 with a face shield and a gown was okay. But when the cases started increasing and if we had to do procedures like ERCP, which probably take a longer time, and a colonoscopy which requires air insufflation, these are the patients who are actually tested also, and if even if negative, they were given adequate PPE to go ahead with the procedure. And also, if it was decided that there was an alternative method available, like instead of an ERCP, if we could probably get away by doing a percutaneous drainage, which is less aerosol generating, we would probably go ahead and do that instead of doing an ERCP.
Okay. Thank you so much, madam. And while Dr. Reena was telling, the other thing she said was terminal cleaning after that particular COVID positive case has been done. Dr. Adna, can you explain, because a lot of people with smaller hospitals really wanted to know which is the best way to sterilize your operating room after a surgery, because some of them don't have designated OTs to do COVID cases. So what would be your advocacy to them?
So I think first and foremost, prefer to have segregation. Definitely, that should be one point. Second is if you cannot segregate, but if it is an elective surgery, maybe you can take it at the last because it would help you do terminal cleaning much better. In between two cases, as we said, we need to do thorough terminal cleaning. Now, this terminal cleaning is basically disinfection. You cannot really sterilize an environment. Max that you can do is disinfection. So WHO has recommended certain disinfectants like sodium hypochlorite. It's also recommended hydrogen peroxide, and there are a lot of other disinfectants that are approved for this particular agent, which one would find on the Environment Protection Agency website of the US. And these should be used to ensure that your surfaces are clean. If possible, I think the best way to do is first clean with soap and water and then go ahead with disinfection. I think that's the better way to work around, because naturally most of these disinfectants will not be able to take care of your organic matter. So if you have, particularly in the labor room where there's so much of organic matter, that organic matter needs to be first reduced in the load. Otherwise, your disinfectants don't work in the presence of organic matter. So if you have a big amniotic fluid splash, let's say, on the ground, a pool of amniotic fluid or blood, that needs to be reduced by soaking on an absorbent material, discarding it, and then using a disinfectant over there, which could be sodium hypochlorite in 0.5% or 1%. So that's about terminal cleaning. While WHO has not advocated fogging, a lot of people do use fogging post every procedure. And here again, you could use the same agents, hydrogen peroxide. There's also silver nitrate with hydrogen peroxide. There's potassium permonosulfate. All of these are available, and one can check agents, compatible agents on the EPA website. And they are available here in India also. I'm not talking about something which is available in another country, but available here in India. So fogging also can be done post procedure, particularly in an OR kind of setup, though WHO does not recommend, but I think it could be done. What's very important is the duration between two surgeries. When surgeries, elective surgeries, are getting posted like this, it is very important that you ensure that at least 1 to 1.5 hours be given to ensure this process of cleaning and disinfection to take place. What normally happens is we post our surgeries back to back, leaving a gap of maybe 15 minutes or 30 minutes. And that probably could make terminal disinfection incomplete, which is one of the very crucial things that happens within the OR. So that certainly needs to be taken care of. And engineering of your OR is very important. You should have ventilation systems, preferably having air changes which are more than 25 air changes per hour. WHO says negative pressured, but many a times it is not easy to have negative pressure OTs, because most of our OTs are positively pressured, and converting them into negative pressures have other challenges. So I think ensuring that your engineering practices are in place and your disinfection practices are in place would help you tide over the cross transmission, which is another risk. So apart from patient protection and healthcare worker protection, the cross transmission or nosocomial COVID transmission should also has importance.
Okay. So thank you so much, Dr. Aruna. I wanted to ask Dr. Reena, one of the questions that in the minds of several people is, mother is COVID positive and she has delivered, and can she nurse the child, or what's the strategy?
Dr. Bala, this is an extremely important question which has been thrashed out and discussed at international and national fora. The take-home message from Royal College, from our neonatology forum and our local guidelines is that yes, breastfeeding with counseling of the mother is recommended. Not only that, rooming in of the mother and child, which was first in the initial part of the COVID era. We have also evolved from February, March up to what is the thing now. Initially, some of the organizations, including the ACOG, had said keep the mother and baby at least 6 feet apart or keep them in separate rooms. Now, all that is out of the window. Skin to skin touch or contact, rooming in mother and baby using infection protection measures, meaning meticulous hand washing and use of mask by the mother is recommended even if she is COVID positive. Breastfeeding, breast milk samples have also been tested by different studies, and there is no proven transmission through breast milk. Yet, our NCGM and other guidelines say that counsel the mother and preferably take a written consent that you have counseled her, but breastfeeding is the best, and we are recommending that. And the transmission to babies in breastfed mother, our NCGM data through the 4 public hospitals has shown a very low risk of transmission to babies in asymptomatic positive COVID mothers. So we are actually following the policy of rooming in and breastfeeding.
Excellent, madam. And another quick question to you. Because the family planning procedures were not available, so a lot of unwanted pregnancies, and then they wanted to go for a medical termination of pregnancy. What is your inputs on this?
So again, this has actually been a tragedy which has come across globally. We had an international discussion with our doctors from the American College of Obs and Gynae, and RCOG also inputs have said that March, April, there was a denial of family planning procedures which ranged from terminations of pregnancy to IUCD insertions. But now, even our government guidelines had initially said elective tubal ligation should be deferred unless it is being done with cesarean section. So there has been a rise in number of unwanted pregnancies. I myself would tell you that there was a case of previous 2 cesarean sections who wanted a termination of pregnancy, but a practical problem. Trains have been shut down. Our hospital was ready to do it. She stayed very far. Now she is due for delivery with a 3rd cesarean because there was no access. So this is just one case. So what the change in guidelines is now that family planning procedures should be made available. And it's not just the availability, access and disseminating the information that women can come to various healthcare facilities after setting up prior appointments with due precautions. We should be offering family planning and MTP procedures. And I would like to just say a word. There was a talk about laparoscopic surgery. There has been a shift from laparoscopic tubal ligation to mini lap tubal sterilization in the COVID pandemic, which has been found in many centers, because both the anesthetist and the surgeon want to avoid general anesthesia. And the same procedure, which can be done under a regional anesthesia or a saddle block, is preferred. Even for termination of pregnancy, initially we used to do it under TIVA. But most of our team, our anesthetists and our surgeons are happy to do it now with a saddle block if required, because we want to avoid aerosol generation. And we are offering the similar services to the patient. So with counseling, unless the patient is very insistent on a laparoscopic surgery, to be honest, we are preferring the open surgeries in our setup.
Thank you. Thank you so much, madam. And
can I add something here,
yes,
Dr. Bala?
Yes, Dr. Vishal. Yeah.
So it's like one of the questions which Dr. Reena had raised is GA versus regional for laparoscopic versus conversion to or versus doing open surgery. So I think one thing which I wanted to add was that we have to keep the patient in mind when we're doing this. Suppose just taking an example of appendicectomy, it can be done open or it can be done laparoscopically, and open can be done maybe under spinal anesthesia. But we also have to think, if we do an open and they are positive, and if they need more opioids, which are going to be respiratory depressants, in this scenario, it might be not worth doing, trying to avoid aerosol generation. We know the PPEs work, So we have to keep the patient's interest in our mind before we shift too far into avoiding aerosol generation. We know that if we do appropriate PPE, it works. And if it is better for the patient to do it laparoscopically, my inclination will be to stick with laparoscopic procedure for the reasons I said.
Okay. Thanks, Dr. Vishal. And Dr. Divatia, sir, actually, you are working in a cancer center, and patients who can't wait, who have to undergo surgery, they come to the hospital. But the chances of getting possibly infected is very high, and also they would be probably immunocompromised. Is there any special things that you did to your unit to make sure that you made the whole process safe for your patient who are coming in? So you need to unmute, sir.
So again, from the point of view of patient safety or even staff safety, most of the things that we did were standard as whatever has been discussed over here. We test all our patients preoperatively with RT-PCR. We make sure that the PCRs are not less than 48 hours before they actually come in for surgery. I know some of the UK guidelines want patients to self-isolate for 2 weeks before they come in for surgery and have a negative RT-PCR. But I think that's not possible with the kind of patients we are getting. We also have the usual screening and for symptoms and all that sort of thing was going on. We have a separate ward where patients are kept in while they are waiting for their RT-PCR. And I mean, the only difference is that many cancer patients cannot wait for the surgery indefinitely. Having said that, patients who have tested positive preoperatively have had their surgeries deferred as far as possible. So most of them, we are able to defer their surgery for about 2 weeks, and then they come up for surgery again. Those who cannot come up for surgery or they are treated as we would with all precautions. And as Dr. Vishal mentioned, I think we do have confidence in our PP, personal protective equipment, and I think it does work. I don't think we've had any great amount of iatrogenic transmission either to patients or to staff because of the way we are working in the theaters. In the theaters, when we are dealing with RT-PCR negative patients, we are not even wearing full PP, but we do wear N95 masks, gowns, gloves, and face shields. Right? But we do wear ordinary surgical gowns. Of course, for the positive patients, we take the full precautions. I don't know. I mean, we are being cancer surgeries. We are not very amenable to regional anesthesia. So almost all our procedures are done under general anesthesia. And I think the surgical conditions, the patient comfort, all that counts. And we are happy to go ahead with the general anesthesia with taking full precautions. The usual things that are there for any other surgery, non-essential staff not to be present during aerosol generating procedures, intubation, and so on. We do crash intubations rather than bag mask ventilation. So again, to try and avoid a little bit of aerosols during the intubation procedure. But otherwise, I think considering what the situation was, say, in March and April, when there was a lot of panic and there was lots of unknowns, I think we have become more confident in dealing with patients, whether it's general anesthesia, regional anesthesia, in the ICU, on the wards, in the OTs. I think as long as we are sensible and we take the routine precautions, I think we have to call these now universal precautions, what we are doing. I think we should be okay, both from the staff as well as the patient point of view.
Thank you so much, sir, for that very lucid answer. Dr. Rakesh, now we have moved on to a stage of initially talking about COVID positives and all. Now we are concerned about patients who had COVID and come with post-COVID syndromes or long COVID syndromes, and they come for surgical procedure. So what is your current understanding on how to deal with COVID patients with some prolonged post-COVID syndrome coming in for surgery? Is there anything that you would look for?
Thanks, Dr. Bala. I wish I had a very good answer for this question. We are still in the initial stages of understanding the long-term impact of COVID, and there's only very couple of studies coming out from mainly small sample studies, observational studies from Italy and Austria, saying that the patients remain impaired in terms of the respiratory capacity and their cardiovascular capacity for 6 weeks and up to 12 weeks. The good thing is they improve with time. That's a good thing. But the bad thing is, in the recent study which was presented in European Respiratory Society meeting, almost 88% of these patients who were symptomatic COVID requiring hospitalization, they had impaired lung function tests at 12 weeks if they got admitted for COVID. We don't know what happens in asymptomatic COVID patients. First and second thing is, there is a registry, it's called Capacity Registry, which mainly looks at cardiovascular outcomes following COVID disease. And it's an open data, anybody can access those resources. And fortunately, they said that cardiovascular complications are very minimal, like the myocarditis, pericarditis, all those incidences during COVID admission was like 0.5, 0.3%. Most patients had more arrhythmias, like rhythm disturbances, and it was like almost close to 9%. And congestive cardiac failure was around 2%, and coronary artery disease was around 1.5%. That is an accumulating data still. We don't know the downward sequelae of this initial problem of myocarditis or myocardial inflammation. We do know from previous viral studies and from previous pneumonia studies that when there is a inflammatory surge, it can affect the heart, it can affect the cardiovascular system, and it can potentiate cardiovascular disease. We don't know whether that's true for COVID or not. But again, the Austrian study, which was just presented, it's not yet published, it's just presented in the meeting, that shows that there is diastolic dysfunction at 6 weeks, and it's almost 60%. But at 12 weeks, it was almost 20% or something. So it decreases over time. And there's also another study showing that, I think the same study is showing that those who cope up better, those who start working on their health earlier, have better outcomes compared to those who don't. And the long COVID syndrome is really perplexing, and it's not limited to those with severe disease itself. The most common symptom is fatigue, like any post-viral syndrome. But there can be other manifestations like breathlessness, chest pain, cough. These can persist for up to 6 weeks again. And that was published in JAMA recently. Apart from all the cardiovascular and respiratory implications, there is neuropsychological implications of COVID too. And it's not just related to depression and anxiety. It could be manifesting as peripheral neuropathy. Some patients have reported Guillain-Barré syndrome kind of peripheral neuropathy too, following COVID. So there are various ramifications due to not only the infectious component, but also due to inflammatory surge and subsequent sequelae. So better part of Valor is to evaluate patient by physical examination and history, and know if there are any residual symptoms of breathlessness, like any routine preoperative examination, and subsequently follow it up with appropriate tests, either by pulmonary function testing, if the patient has respiratory issues still, or perform an echocardiogram if there was suspicion of cardiac involvement, preferably preceded by an electrocardiogram to know any conduction abnormalities. And also maybe a blood gas if you suspect there is some acid-base disturbance or respiratory impairments.
So thank you so much, Dr. Rakesh. And I think it
Dr.
was an
Bala,
excellent...
sorry to interrupt. We are left with 5 minutes. If we can take a few audience questions, and we will be waiting.
Oh, were there any questions at all?
Dr. Bala, you sort of answered all the questions, because as you were asking questions, I was dismissing the ones that were there in the Q&A box. So the audience questions are pretty much what you have actually posted, and so they were clearly. I think you can wind up, get maybe a final view from all the panelists.
Yes, please.
And yes.
Yeah. So we'll start with Dr. Divatia. A take-home message for all.
So I think at this stage of this pandemic, especially when it seems to be winding down, I think the panic is much less. I think we all have understood that if we take adequate precautions, we can do service to our patients as well as keep ourselves safe. And we just need to be sensible and follow the guidelines, follow the norms, and do the best that we can for our patients. But have confidence in your PPE and take the usual precautions. And I think for all us doctors, we must realize that we are at risk not only in the theaters and in the hospitals, but also outside. So please continue to maintain the usual social distancing, hand washing, and the mask, this thing, and encourage all members, your friends and family, to do the same as well.
Dr. Krishna, actually there are just 3 minutes left. So do I hand over the proceedings to Dr. Vijay, and we will thank all the panelists on behalf of GCCMC.
Vijay, maybe you could do that, Vijay. I think Vijay, can you come in, please?
Yeah, Dr. Krishna, my bandwidth is very low. My video is switched off, sorry. So I would like to thank all the panelists firstly for being part of this, and it was really a powerful packed session. It was a new format in which we have tried Q&A. I hope all the participants would appreciate this. And there is a request for all the participants. We have a GCCMC platform, as we have given an introduction. Request everybody to register in it so that you would be getting good knowledge or curated information from this site. And lastly, I would like to thank Wipro for creating this platform to disseminate COVID-related knowledge. Thank you, everybody. And I would like to also inform that on 5th of December, we will be having a topic on diabetes during COVID. So would request everybody to rejoin us on SIM. Thank you.
Thank you. Thank you, Vijay sir. Krishna sir, I think we have a minute left for you to say the final word.
Thank you, Dr. Balavenkat. Thank you, panelists. It's just been so wonderful. I also have another request for you. If you have a few minutes a week, please curate an information or an article into the platform. The biggest, what has been greater than the impact of the pandemic has been the impact of disinformation that has gone on. And I think, we all need to put our hands together to get information right. So we have a forum where it's like a journal club article where, you can choose, for example, Dr. Rakesh talked about a wonderful article that was published recently, but if you can provide a small, even a 5-line summary into the website and give a link to the article, and we will get you in as a curator. Please join in this. This is the only way to beat the pandemic is to stop the spread of disinformation. And I think that's where we are all together. Thank you everyone. This has been so wonderful for your time, for your effort, for your commitment. And this has just been so heartening. Dr. Bala, no words to say thanks to you, but I won't say thank you because you're one of us. We don't thank our own. Thank you once again. Have a wonderful day where, if it's a day there, and have a wonderful weekend, the rest of you. Thank you so much. Please join us in 2 weeks.
Thank you. Thank you, everybody.
Thank you.
Thank you.